morning, respected teachers and dear colleagues. Wish you a very happy Diwali and a good morning. Today I am going to present CCR from the Department of Plastic Surgery. But before that, I would like to invite our HOD Dr. Buddhi Prakash sir to give a brief introduction of our department.
Good morning, respected teachers, seniors and dear friends. सभी को दीपावली और भाई दूज की हार्दिक शुभकामनाएं. Today I am introducing our department. We have 6 faculty members. Myself, Dr. Buddhi Prakash Sharma, Professor and Head of Department. We are blessed to have the renowned plastic surgeon, renowned microvascular surgeon and renowned craniofacial surgeon, Dr. G.S. Kalra sir, who is ex-Professor and Head SMS Hospital. Dr. Manish Singhal, Associate Professor, Dr. Manish Jain, Associate Professor and Oncoplastic Unit Head, Dr. Govind and Dr. Saurav Garg as an Assistant Professor. Our Plastic Surgery Department started in 2013 and MCH course was started in 2016 with 1 seat. Later on in 2021, it was increased up to 4 MCH seats. Total number of MCH residents at present are 8. 2 MCH residents have passed and they are doing very good in their field. Average number of OPD is around 550 and 600 per month and average number of surgeries per month is around 120 to 130. More than 100 publications have been published in national and international journals. We have very good infrastructure of plastic surgery like modular OT, highly equipped with highly advanced microscope and burn unit with well developed ICU and backup. We have all subspecialty of plastic surgery like craniofacial and head and neck, microvascular surgery, hand surgery, burn department, brachial plexus surgery, microvascular surgery, aesthetic, breast surgery and all type of general plastic surgery. Dr. G.S. Kalra sir is present President of Brachial Plastic Society of India and President-elect of Microvascular Surgery of India. Thank you so much. Now I am calling Dr. Ankit to proceed.
Coming to our case, we are going to present a case of a 9-year-old. I am going to present a case of a 9-year-old female child brought by the parents to the plastic surgery department with the chief complaints of unusual shape of the head and the face that was noted by the parents around first year of age and associated with protrusion of both the eyes. There was a delay in dentition. The first incision tooth was erupted at around 1.5 years of age. The patient also had complaint of 4 to 5 episodes of fits that were associated with fever. There were fused middle and the ring finger of both the hands as well as fused all the 5 toes of the both feet. There was a cleft in the palate since birth. So, coming to the chief complaints given by the parents, as we can see, now the case is open for discussion to the house. I would like to ask my colleagues, then can anybody tell what is important and abnormal in this face in this picture and what would be your suggestions to guide us for the further examination and the conclusion of diagnosis? Yes, please.
Eyes are protruded.
Okay.
And the face, that chin is large.
Yeah. The chin is in. Thank you.
Hairline is low.
Yes, sir.
Bridge of the nose is flat.
Yes, sir.
Bridge of the nose is flattened.
Yes.
Nose is abnormally big.
Yes, sir.
And like less development or retarded development of the mandible. That's what I mean.
Yes, sir. Few things are very correct. Like the bridge of the nose is depressed and the flat is flattened and the supraorbital ridges are included. So coming to the history of presenting illness, the child was born normally per vaginally and the parents noted at the time of birth that the child was having they suspected that the child was born without digits in the hands because all the 4 fingers were fused in both the hands, which was found to be syndect. All the digits were fused of the hands as well as the feet, for which she was operated at 6 years of age in other hospital. They also noted cleft in the palate. There was nasal regurgitation of the milk, and the child was unable to suck the milk in the initial periods of her life, which was further advised by the doctor to feed the child with the express feeding with the help of specialized.
एक पेरेंट्स की एजुकेशन हिस्ट्री बताओ और मदर की एंटीनेटल केयर बताओ.
Sir, there was no known exposure to the mother from teratogenic drugs or any radiation exposure. The child was delivered normally in a primary healthcare facility of their local town, and the father was studied up to 12th class of age, and the mother had mother was studied up to 8th class.
Any sonography was done during?
Sir, sonography was done in the natal period, but it was done not from a radiologist. It was done by a...
Which town of the...
Sir, Basawa from Junjunu in Rajasthan.
No, the sonography was done by whom?
Sir, the sonography was done by some local practitioner.
Any intrauterine?
No, sir. There was no documented intrauterine anomaly.
All the scans?
Yes, sir.
Have you taken that into this?
Sir, we have asked in the history.
Not asked. Have they shown you the papers?
No, sir. The documents were not available of the sonography, but on examination and...
Suppose they were available, what you could have thought of?
Sir, the child would have been sent earlier because of the associated anomalies and...
What are the associated anomalies with such type of case? Where the nasal bone is there, flattened or absent?
Yes, sir. Sir,
normal skin. Gynecologist बैठे हैं लोग obstetrician देखा है.
तो डॉक्टर देखो तो कौन आया था थोड़ा लेट आएंगे आप
बताओ.
Sir, in the case when the antenatal sonography shows any congenital abnormality in the child, we should suspect other deformities as well. So, a thorough examination of the skull.
What are the congenital chromosomal 3 common abnormalities?
Sir, Van der Waals syndrome.
Which is that?
This,
which chromosome number?
Sir,
21, 20, 18, 16, 17.
sir, 21,
कौन सा होता है? Addition होता है, deletion होता है?
sir, 20 chromosome number 21, sir.
So it is trisomy. There are 3 pairs.
Yes, sir.
Usually is 1 pair, so one chromosome extra, that is trisomy. 21 is also known as Down syndrome.
Down syndrome.
It is the most common, one of the most common syndrome, which all obstetricians or all ultrasonologists, those who are doing sonography during pregnancy, whether first scan or level 2 or abnormal scan or level 3 scan, they must rule out
Down syndrome.
That is a must, because it is as the age goes on. जैसे ही मदर की एज 30, 35, 40 होती है, इंसिडेंस बढ़ते चले जाते हैं. नंबर 2 is the trisomy 18. That is known as Edward syndrome. Alright, that is usually either they died stillbirth or they do not survive. They do not see even a week of the life. So it's not compatible with the life. And third is the trisomy 13, that is also known as Patau syndrome. So these 3 congenital abnormalities you should suspect. What other thing which you should take into the obstetric history of these patients? Though they have come to the plastic surgery department or orthopedics department or some other department, children specialist, what other causes of the, because these things, they occur during the pregnancy, usually. If you are labeling them as a congenital defect, whether it is a ventricular septal defect or a atrial septal defect or any other defect or some meningomyelocele. But causes are there during the pregnancy. Thorough pregnancy history has to be taken, antenatal, and who has examined, whether the patient was examined, the patient was well screened, followed it was given or not, all those things. Infective causes बताइए क्या-क्या causes?
Sir, the torch infections.
नाम बताओ.
Sir, toxoplasma, rubella, cytomegalovirus, herpes virus.
कौन सा कॉमन होता है?
Sir, herpes and rubella.
Cytomegalovirus. It is complete DNA virus. This is one of the most common. What next cause? One is the infective cause, another is the chromosomal cause or genetic cause, and what third? It's very common. Think of.
Sir, deficiency of the vitamin B12.
So medication.
Medication.
What medication mother is taking? Whether she's on
No history of anti-epileptic medication
Yes.
or
Yes.
phenytoin, thalidomide.
Thalidomide was very popular before World War II.
यूरोप में 10 साल के लिए दिया था सर एज अ सेडेटिव इन प्रेगनेंसी.
Yes, very common. Medication.
Steroids, vitamin A, retinoids.
Steroids से तो नहीं होगा ज़्यादा कुछ. ठीक है. These things you should, and then of course fever and other STIs to be taken.
Alcohol and tobacco sir, the most important.
Hopefully. ठीक है. They should be avoided, must be avoided, but आजकल तो 50, more than 50% of the so-called educated and modern people take alcohol. अपने कॉलेज हॉस्टल्स में चलाएंगे. Thank you, sir.
Coming to the history of presenting illness, the child was born with fused all the 4 fingers and toes of both the hands and the feet, and for which she was operated in other hospital at 6 years of age, in which the second and the fourth web space were separated. There was a cleft in the palate noted by the parents at the time of birth, and initial nasal regurgitation for the milk, for which she was advised express feeding by specialized bottles. The parents noted unusual shape of the head and the face around first year of the age of the child. It was associated with protrusion of eyes. There were recurrent episodes of common cold that were treated by a local practitioner and no significant. There was delayed eruption of dentition. The initial teeth were erupted after a year, 1.5 years of age. There were 4 to 5 episodes of seizures in the child. The first episode occurred approximately around the 2nd year of age, and the last was approximately around the 6th year of age. And these all episodes, as narrated by the mother, were associated with the fever. The child was advised tablet levetiracetam anti-epileptic, and she was currently on tablet levetiracetam when she was presented to the plastic surgery OPD. Coming to the perinatal history, the child was full-term normal vaginal delivery in a primary healthcare facility, and the natal history was not significant. There was no known exposure to the teratogenic drugs or addition to the mother. The past history, she had a surgical history for the
perinatal history को थोड़ा और डिटेल में जाता है. सभी लोगों से मेरी रिक्वेस्ट है जो भी बच्चों के जॉब से पीछे बेस पे जो दिखता है.
there was a surgical history at 6 years of age in other hospital, in which the second and the fourth web spaces were released and the fingers were separated of both the hands. The child had a normal bladder and bowel habits. There was a delay in the milestone development, which would be elaborated in detail by my pediatric colleague, and there was a delay in the dentition. The immunization history is complete as per age of the child. Coming to the family history, we have traced the pedigree of the family for 3 generations, and as we can see, this is the index case, and the child had an elder brother who is 15 years of age, and the parents, along with the maternal and the paternal uncle and the aunts and the grandparents from the maternal and paternal side, they do not have any associated anomaly or any deformity as explained and narrated by the parents on history. So, to sum up the history, we can conclude that the child was having unusual shape of the head and the face. There was protrusion of the eyes. There is hypertelorism. The fingers and the toes were fused. There is a cleft in the palate, delayed in the dentition, delayed in milestones. The negative histories, there is no significant family history among any family member. There was uneventful perinatal history. So I would like to ask the house and my colleagues that these are the observed findings in the history taking. So can anybody please suggest what diagnosis can be suspected on the basis of these pictures? And
तुम कह रहे हो uneventful perinatal history. उसका मतलब क्या है?
sir, the natal and the antenatal history is normal. The
Natal में क्या होगा?
sir,
Delivery क्या हो सकता है?
sir, during delivery there should be obstruction during passage of the child per delivery.
Presentation में क्या हो सकता है?
Sir, in case of the forceps delivery, there could be trauma during the.
हो सकता हो डॉक्टर करेगा वर्टेक्स प्रेजेंटेशन होता है दूसरा कौन सा प्रेजेंटेशन होता है
Sir, brief presentation, sorry
इसमें
sir.
आप खींचते हो ना
Yes, sir.
थोड़ा भी अगर कोई ऑब्स्टिट्यूशन में कोई डिलीवरी कर रहा है वो एक्सपर्ट नहीं है प्रॉपर नहीं है तो कंजेनाइटल डिसलोकेशन ऑफ फुट हो सकता है ठीक है ना अगर पैर को पकड़ लिया तो क्लब फुट हो सकता है कॉमनेस्ट एबनॉर्मल That is perinatal. You must inquire which delivery or vertex delivery कौन सा मेरा है cesarean किया क्या perinatal हो गया antenatal
As well as
around near the pregnancy during the delivery and after
so, any clue from my colleagues? Okay. Down, sir, Down syndrome. Sorry?
Airport syndrome.
Okay. It could be a possibility in this particular child. Anybody else?
Amniotic bands.
Sorry, sir.
Yeah, I said could be a possibility of amniotic bands.
Thank you. So to conclude, on the basis of these observed findings of the cleft palate, syndactyly of both the hands, syndactyly of both the feet, unusual shape of the head, proptosis of the eyes, we can conclude there are multiple syndromes, more than 100 to 150 syndromes that have associated congenital anomalies or developmental anomalies. But the common syndromes that are usually associated in these combination of defects are Apert syndrome, Muenke syndrome, Pfeiffer syndrome, Schetre-Choson syndrome, Van der Waals syndrome, Holland syndrome, or Carpenter syndrome. That we will further discuss and rule out after the physical examination and the local examination. So coming to the physical examination, the child is active, conscious and cooperative, moderately built and fairly nourished. The vitals are within the normal range. There is no evidence of pallor, cyanosis or clubbing, edema or lymphadenopathy. The weight of the child was 20 kilograms and the height was 119 centimeters. Moving on to the local examination, first we will examine the head and face of the child. So we can see in this picture there is a flattening of the forehead, there is a proptosis of the eyes, there is hypertelorism, the gap between the interorbital distances has been increased, there is a transverse widening of the forehead, temporal bossing is evident, the supraorbital ridges are retruded, there is a vertical elongation of the skull and there is a mid-face hypoplasia. An important parameter in the plastic surgery is a cephalic index, which is always taken when we have any unusual head shape kit, which is measured with the maximum cranial width upon maximum cranial length into 100. The maximum cranial width is the biparietal diameter and the maximum cranial length is the occipitofrontal diameter. The normal ratio lies in the range of 76 to 81. Whenever there is a increase or decrease in the ratio, it is confirmed that the child is having an abnormality of the shape of the head. So this child is having a larger than the ratio, it is 90. That comes under the brachycephaly, that is the head is expanded in the transverse direction and there is a short head. Moving on to the oral cavity examination, we noted there was a cleft in the cleft of the soft palate in the child. There is a high arcing of the palate as compared to the normal. There is collapsed arc of dentition. The angulation has been increased. The teeth are in malocclusion. There is anterior open bite deformity. There is no vertical or horizontal overlapping of the upper and the lower incisors. hand and feet examination, there is a syndactyly of both the hands and both the feet. The ring and the middle finger of left as well as right hands are fused with a single nail, and there are previous operative scar marks as evident in this picture on the little ring and the middle and the index fingers of both the hands. The syndactyly is complete. It is reaching up to the tip of the digits. All the toes are affected in bilateral feet. There is absence of movement at the proximal interphalangeal joint and interphalangeal joint of the thumb. There was no movement evident on examination. Other systemic examination were almost within the normal limits of the cardiovascular, respiratory. We did the perineal examination, the external genitalia were normal, gastrointestinal system was normal, and though no muscular or skeletal abnormality was noted in other part of the body. Now I would like to call my pediatric colleague Dr. Nimish to brief about the pediatric examination findings.
Good morning, respected teachers and my colleagues. Generally, Denver development screening is done by the Department of Pediatrics for assessment of development in children, but it is usually done only till age of 5 years. We used VSMS, Venline Social Maturity Scale, in this child, which was appropriate for age and as well as considered for the physical limitations in our child. We are thankful for to the Department of Psychology with their in their help in the assessment. This scale needs at least 1 hour to be evaluated. There are total 89 points on which the scale is done. The chronological age of our patient were 8 years and 7 months. However, upon evaluation, the social age was only evaluated as 7 years and 2 months. That is equivalent to around 84% of social quotient. VSMS evaluates the patient in total 8 domains, that is self-help general, self-help eating, self-help dressing, self-direction, occupation, communication, locomotion and socialization, with unique social age groups in each domain. 84% social quotient classifies the patient as a low average child. The general systemic examination was also done by our department with detailed neurological evaluation. However, respiratory, cardiovascular and gastrointestinal systems were unremarkable. In nervous system, patient was conscious, alert and well oriented. Mental age assessment was done, which was found to be low average category. The child was playful and normal. The speech was slurred and had a nasal twang. There was presence of dysarthria, which presented at distortion of speech. Now I will invite Dr. Rashveer for further evaluation.
Good morning, respected teachers, seniors and colleagues. I will be talking about the radiological findings in the patient. So the 3D reconstruction of CT skull was done, and this is how a normal CT skull in a 9-year-old child looks like. 3D reconstruction, we have done it, and we can see all the sutures clearly visible. This is the sagittal suture, coronal suture and the lambdoid suture. In this image we can see the squamosal sutures. But in the patient, we can see no obvious suture line was visible, indicating that all the sutures were fused, and maxillary bone was not well developed, indicating the maxillary bone hypoplasia, and the intercanthal distance was raised, indicating the hypertelorism. So this is how we calculate the proptosis radiologically. We draw the line between the anterior-most part of zygomatic bone, and then we calculate the distance from this line to the anterior surface of eye globe and the posterior surface of eye globe. So anteriorly we take the cutoff of 21 mm. If it is more than 21 mm, it is considered a proptosis, and posteriorly we take the cutoff of 5.9 mm. If it is less than 5.9 mm, we label it as a proptosis. So in this patient, the posterior distance came out to be 3.7 mm, which is less than 5.9 mm. Hence, we labeled as the proptosis and the shallow orbit. So this is how we calculate the cephalic index radiologically. We take the maximum AP dimension and the transverse dimension. We take the ratio of them and we multiply by the 100. Normally it is 76 to 81, and the patient's cephalic index came out to be 89, indicating the brachycephaly. So this is how a normal 9-year-old child CT head looks like. This is the axial section and the sagittal section. We can see the lateral ventricles and the surrounding brain parenchyma in both the sections. In the patient's CT head, the lateral ventricles were prominent. We can see in the axial and sagittal section as well. But the third and fourth ventricles were not dilated and corpus callosum were well developed. However, no focal brain parenchymal lesion was seen. So this is the CT section to show the sinuses. All the sinuses were well developed, and we can see in this image the sphenoid sinus, the ethmoid sinus, and the maxillary sinus in this image. And well developed sphenoid sinus can be seen in sagittal section as well. So X-ray of both the hands was done, and this is an AP view of both the hands. This is the left hand. And we can see the bony fusion of distal third and fourth phalanges, as well as the interphalangeal joint were fused. And we can see the proximal fourth and fifth metacarpals were also fused in the left hand. And in the right hand, although the third and fourth phalanges were in close proximity, but no bony fusion was seen. However, the fourth and fifth proximal metacarpals were fused. So just to enumerate the radiological finding, we show the fusion of all the skull sutures, that is craniosynostosis, and the small head size, that is brachycephaly, and maxillary bone hyperplasia, hypertelorism, syndactyly, dilated lateral ventricles, and no obvious focal brain parenchymal lesion was seen. Thank you. Now I would like to invite Dr. Ankit to further continue the discussion.
Thank you, Yashveer. As we have taken the multimodality approach in the evaluation of the child, we have further evaluated the child with the ophthalmological assessment. They found that the visual acuity was normal in both the eyes. On the fundus examination, there was no evidence of papilledema. There is hypertelorism was evident in the ophthalmic examination and the proptosis. We took the help of genetics. The genetic counseling was done, and the patient and the parents were counseled and advised for the whole exome sequencing by the genetic. The neurological assessment was done. The neurologist advised EEG for the patient, which was normal, and advised tablet level teracetam to continue, and further follow-up was advised after the surgery. Then we did the lab investigations. The complete blood count, liver and renal function test, sugar, electrolyte, prothrombin time and serology along with the thyroid profile was done, and they were all within the normal limits. 2D echocardiography of the patient was done to rule out any cardiac anomalies. The findings were ejection fraction is 60% with normal cardiac chambers, X-ray of the chest was normal, and the ultrasound scan of the abdomen was done to check for any abnormality or internal organs, and it was all normal. So to summarize the defects, now we can establish on the basis of our history, examination and references that the patient has multiple anomalies ranging from the face, head, upper limb, lower limb and the oral cavity. So in the face, the child was having flattening of the forehead, flattening of the forehead, temporal bossing, mid-face hypoplasia, that is maxillary hypoplasia, hypertelorism. In the head there is a craniosynostosis, premature fusion of all the sutures as was concluded by the radiological examination, brachycephaly and trachecephaly, that is vertical elongation of the skull. In the oral cavity there is a cleft of the soft palate, delayed of the dentition, collapsed arc of dentition and high arc palate, syndactyly of both the hands and syndactyly of both the feet along with symphalangism, that is fusion of the proximal interphalangeal joint of all the digits. So we can conclude to our differential diagnosis, to the final diagnosis. As we have seen, these were the possibilities. So the Poland syndrome and the van der Waals syndrome, these are never associated with craniosynostosis. So these things are ruled out. The Carpenter syndrome and the Shetty-Shojan syndrome don't have cleft of the palate and syndactyly of the hands. So the Shetty-Shojan and Carpenter syndromes were further ruled out. The Menkes syndrome have craniosynostosis, there is brachycephaly, but there is no associated with cleft of the palate or syndactyly. so it is also ruled out. The remaining Apert, Cruzone and the Pfeiffer syndrome, they all have brachycephaly along with maxillary hypoplasia, but the Pfeiffer syndrome have a wide helix that is a great toe on the thumb, but there is no associated syndactyly, so it is ruled out. Cruzone syndrome have brachycephaly but no associated with cleft or limb anomaly, so it is also ruled out. So coming to our criteria, Apert syndrome have cleft of the palate, craniosynostosis, syndactyly of both the hands and the feet, and exorbitism. So it is evident, and we diagnosed this case as a case of Apert syndrome. To give a brief about the Apert syndrome, Apert syndrome is a very rare congenital autosomal dominant disorder that involves multiple aspects of the body, being it the head, face, bilateral limbs, and the oral cavity. It occurs because of the fibroblast growth factor receptor mutation on the chromosome number 10. It is further subclassified into 3 types based upon the involvement of the sutures. Sometimes all the sutures are fused, sometimes particular suture or combination of sutures. So in our case, all the sutures were fused, that is pansynostosis. It is further rare, 18% of the total Apert syndrome have this type of presentation. So this is a case of type 2 Apert syndrome. So after establishing the diagnosis, we have landed up in this particular patient with multiple deformities, and our aim was to correct them. So our aim was to correct the proptosis, correct the craniosynostosis, mid-face hypoplasia, cleft of the palate, syndactyly of the hands and the feet. So all these things have to be built. So we made a plan, and all the things cannot be done in the same city. So we counseled the parents and planned a sequential stage of the surgeries with a gap of 3 months in each surgery. And in the first surgery, we plan to deal with the abnormal shape of the head and the face, mid-face hypoplasia, and to prevent the visual disturbances by correcting the proptosis. So then, since we planned the case, there were multiple anesthetic challenges owing to the prolonged surgery. I would like to invite my anesthetic colleague, Dr. Nupur, to elaborate the same.
Thank you, Dr. Ankit. Good morning, respected teachers and my dear colleagues. I would like to talk about the anesthetic management. Pre-anesthetic workup was done, in which normal vaginal delivery, delayed milestones, multiple episodes of convulsion. Last episode was 3 years ago, but was not on any medication. So injection phenytoin 80 mg 12 hourly IV was given to prevent the perioperative seizures. Ophthalmic examination to rule out increased intraocular pressure and intracranial pressure. Airway assessment. Mouth opening was adequate with 3 fingers. Thyromental, hyomental, sternomental distances were normal, though she was a case of difficult intubation because of mid-facial hypoplasia, prominent upper incisors, high arched and cleft palate, overcrowding of teeth, and Mallam putty grade 3. Mallam putty indicates the space of the oral cavity so that we can accommodate the laryngoscope and endotracheal tube. So it has 4 grades, in which class 1 and class 2 tells us about the easy view of the glottis during the laryngoscopy. Class 3 and 4 tells us about the impossible and the difficult view of laryngoscopy. So what were the challenges? Due to the mid-facial hyperplasia, prominent upper incisors, high arched and cleft palate, there was difficulty in bag mask ventilation, difficult laryngoscope, difficult intubation. Due to the surgery, prolonged duration, risk of hypothermia, anticipated blood loss and hemodynamic instability, and ICP management. Due to the cleft palate, there was increased airway irritation and secretions. So how we did it? Standard monitoring were done with SpO2, electrocardiogram, non-invasive BP, temperature, end-tidal CO2 and urine output. Difficult airway trolley was kept standby with all the necessary airway equipments. This is the Corman-Sleehan's grade, which tells us about the glottic opening during the laryngoscopy. So our patient was under grade 2B, where just only the posterior commissures are visible. There is no visualization of the vocal cord. So this blue-colored gum elastic bougie was inserted through this opening, and then reinforced flexometallic cuff endotracheal tube was railroaded over it, and the airway was secured by placing the ET tube centrally. ICP was managed By maintaining the anesthesia through isoflurane air and oxygen, nitrous was avoided. EtCO2 was maintained at 32 mm. So because it increases the intracranial pressure, because cranial vault is a closed space. EtCO2 was maintained, balanced salt solution, Ringer lactate was used, dextrose was avoided and sugar was monitored every 2 hourly. Hemodynamic stability was maintained by appropriate fluid replacement and blood transfusion, and normothermia was maintained through this Behugger warmer. हाँ जी सर, हाँ जी सर. So we could use it, but we did not use it in this patient.
Oh, you did the boogie and the railway.
Yes. Fluid requirement was mentioned.
Visualization for negotiating, you again have to use
our anesthesia department is really commended.
जो difficult surgeries करते हैं लोग जो है से.
Hats off to them.
Yeah.
Fluid requirement was maintained through holiday cigar formula. Blood loss was estimated to gauge visuals and the suction jar. 250 ml of packed blood cell was transfused intraoperatively, and the whole surgery was uneventful, and the patient was shifted to PICU and elective mechanical ventilation. Now I would like to call Dr. Ankit for the further discussion.
Thank you, Nupur. Once the pre-anesthetic checkup and all the things were done, we proceeded for our surgical management. As we have discussed the multiple challenges and deformities, we planned for the cranial vault reshaping and remodeling with mid-face advancement and correction of the orbital proptosis. So this is being done by the fronto-orbital advancement and remodeling and Lee-Foot 3 osteotomy, in which the mid-face was advanced.
Before we proceed further, please mention about the incidence of Effort syndrome, how uncommon.
Sir, incidence is, sir, it is 6 to 12 per million. Yes, sir. And further, this is a case of type 2 Effort syndrome, which is 18% of the total. So it is approximately 2 per million population. So it was very rare case. So this was our first surgery. How we approached, as we can see in this depicted picture, it was a bicoronal incision we have given, and the flaps were raised anteriorly by the subgaleal dissection. Then the flaps were projected anteriorly and up to the superior orbital rim and exposing the superior orbital rim in the frontonasal suture line. Yes, sir. Exposing the supraorbital rim. The supraorbital neurovascular bundle was taken care of because there is a supraorbital foramen just above the supraorbital rim, which was osteotomized with the help of a sharp blade osteotome to end up projected, and it was projected anteriorly to prevent it. Then the incision was taken up to the tragus bilaterally in front of the ear, and the Lee-Foot 3 osteotomy. It is a surgery for the advancement of the mid-face because there is a maxillary hypoplasia that has led to the hypoplasia of the mid-face, and it is retruded. So we have to advance it up to approximately more than 1 centimeter. So the osteotomy cuts were given as we can see in this picture, because the real-time photograph is not possible in that particular surgery. The frontonasal sutures were separated, osteotomy cuts were given here, moved medially. The this is the frontal bone and the nasal bone. So these both bones are disjunction, and the incision is given at this site. It is moved on laterally to the frontal process of the maxilla, then moved medially into the medial wall of the orbit, following the inferior movement of the incision on the inferior orbital rim by elevation of the periosteum towards the lateral orbital rim, and then down up to the inferior zygomatic arc, inferior aspect of the zygomatic arc. Because these incisions are not possible after the advancement of the cranial bone. So first we did the osteotomy of the Lee-Foot 3 mid-face advancement. Followed by this, we did the parietal bone cuts, then the frontal bone cuts, and supraorbital rim, that is called as the supraorbital bending above the eyes, is separated and is taken out along with the frontal bone. This bone is remodeled outside the body. It is called as frontoorbital remodeling. In case of the defects, the bone can be shaped into a desired manner. Yes, sir, it's okay. Then the bones are replaced in an anterior advanced position. We did an advancement of approximately 2.5 centimeters, and the bony segments were fixed with the help of titanium plates of 2.5 millimeter, and the bones are fixed, as we can see, along the lateral orbital margin and along the zygomatico-maxillary lines, and the frontal bone is placed and it is also fixed in 2.5 centimeter advancement to correct the hypoplasia and the cranial vault brachycephaly.
टोटल ऑस्टियोटोमी का कंसेप्ट है
जी सर,
वो किस फंडामेंटल बेसिस पे बेस्ड, व्हाट इज द बेस ऑफ osteotomy? Why do you do that? Whether it is a hip or whether it is correction of the club foot or correction of the knee joint in the children, what is the concept of osteotomy? Why do you do the osteotomy?
Sir, we did the osteotomy to increase the intracranial volume so that the brain can expand. Otherwise, the decreased volume will lead to the increase of the intracranial pressure and deformities, and it is based on the principle of distraction.
ये जो आपने लगाए हैं
जी सर,
टाइटेनियम स्क्रूज और जो भी हैं,
जी सर,
तो वो कब हटाओगे?
sir, if there is any problem with these screws, then we will remove it. Otherwise, since the child is 9 years old, we will let it inside the bodies, because maximum head and face development has already occurred by the 4 years of age. If there is any infection or any associated anomaly, the child is having outpouching of any implant from the head, then we can remove it. Ideally,
Dr. Kalra, can you explain the purpose of osteotomy? I think it is the regeneration of the bone which leads to the further improvement.
The purpose of the osteotomy is here. Number one, patient had intracranial hypertension. The pressure was already more. If you see a CT scan, you will find a cerebrospinal appearance. So, over a period of however, in this patient it was not there, but most of the patients, if not treated, they can develop blindness. Secondly, because apart from the skull suture, the skull base sutures are also fused in crucian and upper, and that is why these patients develop hypoplasia of the midface, and we have to advance that also. And by advancing the bone, we will give a space, and in between area we usually leave open and it heals. It generates new bone.
Basically, it's a distinction of the
In adults,
So the
yes,
purpose is to develop the bone.
more bone, yes.
More bone. Otherwise, general concept is that osteotomy तो आपने bone निकाल दी तो हुआ क्या? Basically ऐसा नहीं.
It will generate new bone.
New bone. ठीक है ना?
Especially in craniosynostosis, sometimes there are other techniques like doing endoscopic, but all they usually they get again fused. So that is why a good advancement is better.
yes. Sir, secondly, the ideal material, as you have asked, is the bioabsorbable plates are available in the market. But the next available best option was titanium. Owing to the resource limitations, we usually use these titanium plates in most of the institutes. After that, the temporalis muscle was repositioned and the incision was closed in layered. This surgery looks simple, but we have to take care of multiple things during the intraoperative time, since there was a enlargement of the brain within the short skull. So there was a dense attachments of the dura mater to the underlying cranial vault that have to be taken care of. Otherwise, a slight speed of the surgery or uncontrolled manner would have led into the damage to the dura mater. Secondly, during the remodeling and lifting up of the supraorbital band above the supraorbital rims, it can lead to injury of the globe. There could be optic nerve injury that can lead to a permanent damage to the vision of the child. And mid-face advancement can lead to the CSF rhinorrhea. There could be damage to the ethmoid cells. There could be a damage to the nerves, paresthesis of a particular region. So these things were to be taken care of, and fortunately we were able to do it without any such things. Post-operatively, as it was a prolonged surgery, the child was allowed an elective mechanical ventilation, and we shifted the child to the pediatric ICU, where she was very well taken care of by the pediatric intensivist team. Anticonvulsant prophylaxis was being done by double anti-epileptic drugs of phenytoin and levetiracetam, and we put the patient on the piperacillin tazobactam along with metronidazole. Overall, post-op course was uneventful. The child was kept on the mechanical ventilation on the same post-operative day, and on the day 1 she was switched to the CPAP, and 1 unit of blood transfusion was done after getting the complete blood count reports of the child. On the second day she was extubated and shifted to the high flow nasal cannula therapy. On the third day the drains were removed and the child was shifted to the ward, and we started on the liquid diet that was gradually increased in quantity and frequency. On the 4th day, we took her on the semi-solid diet and discharged on the 7th post-operative day. But before discharge, since we have planned that the child is requiring multiple surgeries, so we counseled the parents and the sensitization for the next surgery was done, and the child's parents were advised for the strict supervision of the child at the home and particularly during the playing episodes. This is the post-operative X-ray, in which we can see the fixed advanced cranial vault and the mid-face, and in that picture, as sir was saying, this is a classical sign of copper-beaten appearance that is present because of the convolutions on the inner cranial vault because of the raised intracranial pressure. Post-surgery, after 3 weeks and 2 weeks, we followed the child every week for first 3 weeks. So this is the difference we can see in the pre versus post-operative picture. The proptosis is improved, flattening has improved, there is no infection on the scar line, supraorbital ridges were protruded as previously they were retruded. There was an improvement in the mid-face hypoplasia. In the frontal view, this is the bird's eye view as seen from the superior aspect of the child. We can see a well documented picture itself showing the supraorbital retrusion and the proptosis, while in this it is corrected much. This is the lateral and oblique view. So after that 3 months of the initial surgery, we planned the second surgery, in which our aim was to correct the cleft of the palate and the syndactyly of both the hands. So I would like to ask my colleagues that the child was also having syndactyly of the feet. Can anybody suggest that why only these 3 surgeries were being done in the same sitting, or why previous history nobody has asked that why the syndactyly of the ring and the middle finger was left behind by doing the surgery of only the second and the fourth rib space. Syndactyly you are talking about? Sorry? Pardon please? Proptosis has already been corrected in the first setting of our surgery. I am talking about the syndactyly of the hands and the feet as well as the cleft of the oral cavity. We are left with these findings now.
Maybe the serious thing has to be taken care of. It's a long surgery.
Yes sir. Second thing sir, syndactyly of both the hands and both the feet should ideally never be done until and unless there is an emergency or you are very much sure that the child is not going to be come back or she is neglected, because you cannot immobilize all the 4 limbs together. Otherwise it will be a very morbid condition for the child and the parents, especially the child is not a infant, she is a 9-year-old female child. So ideally surgery of the upper limbs or lower limbs can be done. the cleft palate repair was done. These surgeries we used to usually do in the plastic surgery department, so we have not elaborated in detail in this common clinical round. This is the difference that we can see. The cleft is closed by the repair. It was done on 21st of September after the 3 months of the first surgery. And syndactyly of both the hands were done. During this surgery, since the three defects were being approached, so to decrease the anesthesia exposure and the operative time, we employed 3 teams simultaneously working on the cleft palate and both the limbs to decrease this time.
जैसा भी एक्सरे में जब डिजिटल फ्यूजन था स्किन में मसल था तो मस्ट बी इजी वो भी जुड़ी होगी ना वो एक में जुड़ी और इसमें भी जुड़ी वो भी कार्ड गाड़ी सिंपली नाइट की बहुत सॉफ्ट होती है और ग्राफ रहता है आराम
Sir, apart hand is also a different entity that has been elaborated in detail because multiple associations or multiple type of presentations are there. Sometimes all the digits are fused with a single rosebud-like thing. Sometimes 3 digits are fused, sometimes 4 digits are fused. But in apart, there should be at least fusion of the 3 digits of both the hands. And it is also called as obstetrician's hand. Particular apart hand is called as obstetrician's hand because of the fusion of 3 or 4 fingers. So because of the per-vaginal examination, the position of the hand and the fingers were being abducted, sir.
Because when you take out the head, you make the position of your hand like this.
Yes.
That is why
probably
that is why it is not an obstetrician.
Yes.
When you take the head and you make the cup sort of thing.
Yes, sir. Then after the third surgery, this is a protocol to take the picture of the child in plastic surgery in all the aspect, be it frontal, oblique, lateral, the worm sign, bird's eye view. So we can see the better picture right now after 3 months of the first surgery. This is the lateral view showing the elongation of the head, the flattening of the forehead, proptosis after 2 weeks of the surgery, and this is image post 3 weeks of the surgery in which we can see the corrected proptosis, retruded eyelids, mid-face hypoplasia, flattening of the forehead, and a well-hidden scar. With the help of a bicoronal incision, there is no evidence of infection and the child is happy. Besides this, we can see there is a shortening and retrusion of the upper lip that has also been corrected with the help of mid-face advancement. And aesthetically, the parents were very much happy and the child was quite doing better. This is the lateral view of the same child post 3 months of the follow-up. So, coming to the further advancements in the craniofacial surgery, we now have a CAD/CAM software with the help of which we can make with the help of CT scan films, the mock models of the skull can be done and the mock surgery can be done pre-operatively. And the cutting of the bony segments and osteotomy can be done, which helps for the precise cut and the advancement of the surgery. Now I would like to invite Dr. G.S. Kalra sir to give a take-home message and the acknowledgement. Thank you, sir.
What about
Thank you, sir.
procedure?
Sorry, sir?
Was the patient investigated procedure?
So seizure was febrile seizure. We got the evaluation done by the pediatric as well as the neurology department. The EEG was done and there was no post-operative episode of seizure till the 3 months of the child. So they assumed that being the normal EEG, there is no obstructive hydrocephalus, only dilatation of the lateral ventricles. So they said we continued with the tablet tiracetam for 3 months, and they said that the child was not having any other seizure disorder. Basically.
We have Dr. Goenka from Ohio.
Okay.
Neurologist.
Okay. Yes, sir, please.
Thank you, sir. So, Miss, I agree with sir. Like, it's very unusual that you start at 2 years of age, then you continue till 9 years of age.
No, sir. No, sir. The tablet levetiracetam was started at 6 years of age when she had the last episode of seizure. Initially, they took the treatment from the local facility of their town in the Junjunu. After that, on the last episode, they took the help of a pediatrician According to the parents, certain investigations were done, but the documents were not available before 3 years of the 3 years back. So they said that this is the medication going on since then.
Typically, we stop the medicines after 2 years seizure freedom. That's the typical.
So
I don't know like why it's continuing on and on and.
So because the proper, they would not have followed up properly, sir. Because since they have been such much ignorant, they were ignorant, otherwise the child would have been operated earlier at the best stage of the study. Now, please, please call us. Thank you.
Thank you. And good morning, everyone. And I especially thank the Chairman Emeritus you have given this hospital, such a well-equipped hospital to the public, and very difficult to find. Now, ideally, all these patients should be, number one, operated very early. A cranial stenosis, actually all these diseases, for example, syndactyly should be operated before the age of 1 year. Cranial stenosis should be operated before the age of 1 year, because the brain expands, and we do not want to increase that intracranial pressure to have a side effect on the brain and the eyes. So ideally all should be done, but this patient somehow, he had consulted me before, but somehow didn't agree to undergo skull surgery because he was very much worried. Then basically the surgery has become safe because of the advanced anesthesia and better care. And now this is the during Diwali, now see how happy the patient is because of the release of sympathy. Now she is holding these, enjoying. We are also very thankful to the PR department of the hospital to spread the message to the public that these surgeries can safely be done in our hospital. And this is the only department in Rajasthan where this type of surgeries are being performed. This was the other patient of trigonocephaly we had done a few days back. And I have basically over more than lower one is a rare craniofacial cleft, upper one is occlusion. My experience with the craniosynostosis syndromic and non-syndromic is over more than 200. I have one of the biggest series in India and biggest series of rare craniofacial clefts which I had presented in Barcelona International Conference and in one conference where all the big people of the world, and I also presented with them in Asia Pacific craniofacial meeting. And they praised because of my series was very long. I have around 176 cases of rare craniofacial clefts. Every type of craniofacial clefts we have. And that is for orthognathic surgery. We have over 500 cases of orthognathic surgery. We have, my concept now is any bone can be cut and remodeled and shape can be improved. And facial palsy. More than 200 cases of facial paralysis where we use free gracilis muscle innervated by either dual innervation or single innervation using cross facial palsy. Again, it is the biggest series in India. Thank you, sir. And also very thankful to the parents, hospital management, this Chiranjeevi, the hospital, this patient, otherwise I think would have spent at least 25 lakh rupees. And we have done it free of cost. So we are highly thankful to the hospital management and these And we are thankful to the Department of Anesthesia, Department of Pediatrics, who has taken absolute care in the post-op care. And Department of Neurology, our neurosurgery, we had already informed them that we are going to do, in case we are in trouble, we are going to invite you. And staff of the OT and ICU. Thank you all. Thank you very much. And all these departments are excellent departments.
Tremendous planning, and these are never before procedures done here for the first time.